Hey everyone, we are going to talk about menopause and nutrition today. So let me share my screen. Okay, hormones and nutrition. I'm Hillary from Apothecary Company, and this right now is a huge topic. So we've got to kind of go through and figure out, well, what's myth versus reality, right? We've got misinformation or even good information coming from healthcare providers. We're getting information coming from social media, society. They have their own expectations and what dealing with hormones have been in the past, and then just our women friends. They're maybe sharing some good stories. Is it myth versus reality? So I'm hoping to clarify all those today. So, a study demonstrated that on average, it can take up to 13 months for women to link their systems to or their symptoms to perimenopause. So, hormone diagnoses or just even thinking about hormones come a long time after it actually is doing its thing. So, in the same study, 90% of the women failed to link their symptoms to fluctuating hormones, instead, linking their symptoms to stress, depression, and anxiety. So, the reason why a lot of times we are seeing just medications um, being filled and dispensed rather than looking at root cause, which this is what we do. Research also suggests that only 3 in 10 women feel well informed about menopausal symptoms. And again, we just talked about that. Who do you believe? Where do you get your information from? And then beyond that, sometimes it even takes multiple visits for the doctors to diagnose you correctly before we even talk about menopausal symptoms. And often it takes, again, 13 months to kind of figure that out. So it is, it's something that we need to bring light to. Bloody facts. I think we need to set the stage of what's normal and how much blood we're actually losing and what part of this whole scenario is plays a big role in our day to day, month to month, um, our life. So women have their period every 28 days, and we know that that's the average. That means on average 521 times in a lifetime. If we bleed for an average of 5 days, 521 times in a lifetime, that is 7 years of continuous bleeding. We lose an average of 150 mLs of blood per period. So that means we lose 391 liters of blood per life. But to put that in perspective, an average man has 6 liters of blood running through their system at any particular time. So the amount of blood in a woman's lifetime is equivalent to 65 men. So that's huge. That's a lot. And I think we downplay that because a lot of times what we're finding now is that we are dealing with iron deficiencies. Hormones, they follow a certain pattern throughout a woman's monthly cycle. There's the follicular phase from the time you start your period, which is your menses, all the way up to 14 days, which is when you generally ovulate. Then it becomes the luteal phase up to from days 14 to 28, and then you start it over. But if you look at this graph, we'll see that estrogen does its own thing, right? It continues to rise after you start your period. It crashes when you ovulate, and then it kind of rises again and goes down. Progesterone's kind of more of a steadier growth. Ovulating is when it starts peaking up, and then it will drop prior to you starting your period. You'll see luteinizing hormone and FSH. We'll talk more about that when we get to the menopause. But estrogen and progesterone are the things that are the hormones that are becoming very cyclical around our cycles. Estrogen roles, just going into it, estrogen is very important. It's one of the hormones that we need in our body. Same with men, but there's mitochondrial support, which is more energy in the cells, apoptosis, which is more cellular protection, cancer protection. It affects our brain, our mood, sleep, bones, eyes, ears, weight, hair, skin, mouth, mucosal barriers, bring in moisture, like vaginal dryness. That would be an example of mucosal barriers. Metabolism, sexual function, muscle and connective tissues. Huge amount of roles it plays in our day-to-day lives. And then it supports heart, vascular, it's an anti-inflammatory, it's antioxidant. We have estrogen in our bladder, colon, gut, immune system, cancer benefits, and they are all protective. It doesn't necessarily have to mean that estrogen is bad. And we'll talk about that in a little bit. So when we go into this menopausal transition, right, we usually start perimenopause. It's late 30s. Uh, and here it says age 40 to 44. So this is just like a little timeline. But from 40 to 44, our periods will start becoming regular. They're going to get irregular, irregular again. So they're going to bounce back and forth. Progesterone will decline. And if we have any menopausal transition symptoms, it's going to be mild, if any. We're not going to notice anything. It's going to be these slight changes. Maybe our periods are lasting a little bit too long. Maybe they're not lasting as long as they once did. And then we'll progress from 45 on in their mid 40s, late 40s. We'll have irregular periods. Our progesterone is still decreasing. Our estrogen becomes erratic, where it's up and down all the way around, or its symptoms become moderate. Maybe we're having some hot flashes, mood symptoms, can't sleep. Now, what defines a true menopause situation is when you have 366 days of no bleeding. That's your from your last menstrual cycle. Welcome to menopause. We do have some hormones that we can check in the blood. LH, luteinizing hormones, and FSH, follicle stimulating hormones. They typically have to be elevated for menopause, but we've got to take a whole bunch of type symptoms and things going on in context. If we progress to the early 50s, estrogen was very low, progesterone could be very low, and then our metabolic health is silently declining. Metabolic is more metabolism, it's our aging process. So things are starting to kind of diminish. And we'll talk more about that, but that's because these estrogen and progesterone, we don't have any readily available to produce these benefits any longer. And then mid 50s and beyond, metabolic health is worsening and our health span is now at risk. So when we talk about anti-aging and bioidentical hormones, that's where this comes into play. Perimenopause or premenopause, before we get to perimenopause. So premenopause, this is just normal cycling women from, the time you do start your period up to, let's just say, average of 35, 38. We'll have irritability, we'll have cramps, maybe we can't sleep. We'll have some vaginal dryness, maybe some mood swings. Periods will become heavy, they'll become short, we'll miss a month. That would be premenopause. And at that time, I think it's very important to kind of get an idea and a grip on your cycles at how nutrition is playing a role in supplementation and how to manage that before getting into perimenopause. Because if you don't have any of that under control and you're like, let's just say B vitamin deficient and magnesium deficient, you're going to have a harder time going through perimenopause. Or maybe you are eating a lot of processed food and you don't have enough greens in your diet or cruciferous vegetables, you're going to have a harder time through perimenopause. So perimenopause, you have regular periods, you might have some weight gain, night sweats, hot flashes, loss of libido, and then boom, last period, right? So remember last period, 365 days. If that happens, menopause. If it starts at 363 days, then oops, you're starting all over and you got to count a year again. So menopause and postmenopause, different types of symptoms. We're looking at more and paying attention to more bone health, osteoporosis, osteopenia. We might have more urinary infections because of our estrogens diminishing, heart disease, depression, increased breast cancer risk, vaginal discomfort. So it's a timeline. And it's kind of interesting to me because this date and this year is very it's very close and near and dear to my heart because perimenopause, women born before the 1985 like say 1984, are likely to be in perimenopause currently. We don't think about that. We just think we're still cycling and our periods are getting a little bit wonky, but you're probably in perimenopause. Different phases of perimenopause, and most people don't really pay attention to this, right? We just, again, it's a span of, shoot, it could be anywhere from 1 to maybe 10 years. But most people will go through these different phases. So phase one, periods are still regular, but symptoms are starting. This phase can last 2 to 5 years, and usually we're having high estrogen, low progesterone. Yes, what kind of symptoms? That's heavy periods, that's cramping, you probably can't sleep, you feel maybe weight gain. So this is a time of what we call estrogen dominance. Phase two, cycle length starts to vary by more than 7 days. So we're skipping periods, we're not having any, maybe we're having they're too long. But estrogen is still high, but fluctuating more widely with some real low points. So we could have those high estrogen symptoms again. Maybe we're having breast pain and tenderness. Estrogen withdrawal symptoms like migraines and night sweats are starting. And then the timing from the onset of our regular cycles to the first skip period is around 2 to 3 years. Phase three, when cycle length starts to vary more dramatically, we're up to 60 days, maybe missing a cycle. Estrogen is getting lower, but still fluctuating up to some high points, but not as roller coastery. And then phase four, the time between what you think might be the final period in achieving menopause 12 months later. So here we're very low in estrogen. So we just had a conversation, a colleague and mine, and we were talking about how some practitioners are wanting to give estrogen through perimenopause and doing a bioidentical hormone. I don't know if that's a good idea, and this is just my personal reflection, because estrogen, as we can read here, is going up and down, and there's no way to really control it. So 1 month you could have high, next month you could have low, the next month and the month after you could have high. So there's no sense in really giving supplemental estrogen, because you might be causing more symptoms. But again, I mean, that's why it's a personalized approach, right? So you have to kind of time it. The other thing is, at this point, because things are fluctuating, it's going to be hard to keep track of your cycles. Perfect time to start a cycle tracker. What does perimenopause mean? It means around menopause. There's two different organizations that kind of define menopause. The North American Menopause Society, they're saying perimenopause will last 4 to 8 years. Center for Menstrual Cycle and Ovulation Research says 6 to 10. So we've got two organizations that disagree with timelines. So again, it's a little bit confusing. We talked about estrogen levels averaging 20 to 30% higher than premenopause. We talked about higher likelihood of depression. Fertility diminishes, but it doesn't mean that you cannot get pregnant until the official date of menopause. And then women will often, but not always, start transitions about the same time their mother did. So if you can have a conversation about family history, that might give you an idea. If you have estrogen deficiency symptoms and you're slipping into this menopause phase, well, that could look like hot flashes, sleep disturbances, or you're having low libido, bone loss, vaginal and bladder infections will become more prominent. Night sweats, memory loss, bone issues will kind of come into play, which I talked about bone loss, vaginal dryness, vaginal atrophy, memory loss, lapse, brain fog. We can also add headaches in there, weight gain, specifically around the waist, heart palpitations, because what we're looking at is this estrogen dominance. Estrogen doesn't have enough progesterone to balance it if you're estrogen dominant. So that often manifests as heart palpitations. If you don't have enough progesterone, that's heart palpitations. Foggy thinking, painful intercourse, depression, dry skin. So estrogen does a lot. Progesterone will also start dropping. We did talk about that. That's swollen or tender breast, cramping, depression, acne, oily skin, excessive bleeding, weight gain, anxiety, joint pain, PMS symptoms, infertility, fuzzy thinking, headache. Whew. They mimic each other. So again, estrogen and progesterone have to play well together and they've got to be balanced. It isn't necessarily about estrogen levels. It's not necessarily about progesterone levels. It's all that combined, but how they balance each other. So as time goes on and we're into this perimenopause, eventually the time's going to stop and we're going to be diagnosed with menopause. Again, 365 days of no bleeding. Different symptoms of menopause. Most of the things we just talked about, right? You can have some dizziness, anxiety, irritability, shorter, longer cycles, bleeding between periods, um, dryness, painful intercourse, urgency, incontinence. So things could start going awry. And no wonder why it's so hard tracking down of putting our finger on our diagnosis of just menopause, right? Our thoughts go to other things first. Women over 50 compared to men. Women over 50 account for more than 80% of all breast cancers and have an increased risk for colorectal cancer. They also have 4 times higher rate of osteoporosis and 2 times higher rate from osteopenia than men over 50. 2 times the rate of dementia and Alzheimer's, comprising 70% of the cases. 2 to 4 times the incidence of anxiety and depression. And why is that? It's not all about the typical hormone symptoms. So here we can see that estrogen provides a great benefit. And once we lose that, then we're more at risk. It goes on and on. It can go into autoimmune diseases. 9 in 1 women over 50 have lupus and been diagnosed with lupus. 2 times likely to have more sleep disturbances, insomnia, and restless leg syndromes. So again, ovaries are done. We are dropping in progesterone and estrogen, and we're not protected any longer. But why? What's the cause of natural menopause or just menopause itself? Is because our ovaries have basically shut down and we do not produce the hormones any longer. That's just natural. That's age. That's not pathologic or physiologic cause. If it is because of pathologic causation, it could be that your ovaries are just maybe not working as proper as they should. That's premature ovarian insufficiency. So that's when a woman's ovaries stop working at a very early age. And then it will affect 1 to 2% of women by the age of 40. So that could be part of that situation. Or maybe you've just had to have surgical menopause. So that is the women who have had surgery, hysterectomy, to remove their uterus, but maybe they left their functioning ovaries. Menopause is still not considered to have yet occurred, right? Because you're still producing your hormones through your ovaries. You just removed the uterus. But if you remove the uterus and the ovaries, now you're in menopause. And symptoms could happen a heck of a lot earlier than most. So we've got to define the causes first. And again, I told you that the diagnosis is suggestive, right? Typically, the conventional medicine space will just do FSH and LH. If they're high, then welcome to menopause. There's different types of or psychological scales that can give us an idea of menopausal symptoms. It goes beyond this, in my opinion. We need to have a talk about what's going on and kind of get a bigger picture. It isn't about picking up these little pieces. I do want to warn you here that Clear Blue, the place that does the ovulation and pregnancy tests, are doing a menopause stick. And it's telling you, and it will calculate premenopause. Are you in early perimenopause, late perimenopause, postmenopause? Okay, I like it. It will give you an idea. But my argument's going to be is what are you going to do with this piece of information? Nothing. Nothing. There's things that you can do to help support your body, but these different stages will not change our course of action. So I'm just telling you, it may be cool to know, but you can't take this information and give it to your doctor and expect them to do something about that. Same thing, Everlywell through Amazon does the same type of thing, a take-home test. You're perimenopause. It is what it is. Things are not going to change. Um, so you could save yourself $78. Moving into metabolic health and wellness. So declining estrogen and other hormones are going to affect how we handle glucose and insulin. It's going to affect how we signal hunger hormones. We are going to be affected how we store muscle mass. We're going to have more loss of muscle mass, slowing the rates of calories that we use. It's going to lead to slower metabolism, leading to overeating and inflammation. And then eventually it will disrupt sleep, weight gain, poor stress handling, and cortisol shifts. So that's a women's disadvantage, right? A declining estrogen. Just to throw this out there, metabolic syndrome. Sometimes they'll use this term. It does affect 1 in 3 women, but that's when your circumference is bigger than 35 inches. You have a fasting blood sugar of over 100, so you can't regulate your sugar as often or as good as what you once did. Your blood pressure becomes creeping up. You're moving over 120 over 80. You become pre-hypertensive, maybe even hypertensive. Triglycerides are going to be over 150. And then your good cholesterol is going to be under 50. This is what's labeled as metabolic syndrome. So if we look at laboratory evaluation, and sometimes it's not about hormones, right? So if you go to your OBGYN and say, check me, see if I'm in menopause, what's my estrogen, what's my progesterone levels, they'll tell you. But in a functional sense, we want to make sure that your body can manage those hormones properly, produce those hormones properly, and detoxify them. So we're looking at through blood work, we're looking at CBC with a differential. Are we dealing with any sort of infections? Are we dealing with anemias? I want to know what your iron is doing. I want to know what your ferritin is, your iron stores. Sometimes people have heart palpitations just because of low iron or ferritin. It's not a hormone problem. So we want to rule out all these nutritional deficiencies first. We're looking at complete metabolic panel. I'm looking for liver enzymes. What if we have any gallbladder issues? And we can look at GGT. I'm looking at a lipid panel, vitamin D3. I want these ranges to be in the optimal ranges. I'm not buying just the reference ranges. So for instance, vitamin D is a perfect one. Their range is anywhere from 25 to 100 as being normal. Well, if you're under 40 for vitamin D3 um, serum levels, you're going to be very tired. You are going to have brain fog. Your sugar modulation's not going to work proper. You're going to have immune system issues. You're going to just going to be overall just fatigued. So rather than blaming that on hormones, I want to assess that first and fix that if necessary. Looking at B12 in the blood, homocysteine, that's a marker of detoxification and how you're utilizing your hormones. HSCRP, if that's elevated, you're going to have a harder time losing weight. But we have to figure out what is inflaming you. It's more of a cellular inflammation. It is not a representation that your joints are necessarily going to be achy, but it's your body's overall inflammatory burden. What's your average sugar over 3 months? How much insulin are you producing to keep that where it needs to be? I want to know what your thyroid hormones are doing. One step further than the TSH and free T4, I want to know what your free T3 is doing. That's your active thyroid. They don't check that. So I want to know exactly what's going on there. And then a good practitioner who knows hormones should be checking estrogen, progesterone, DHEA. We'll talk about pregnenolone in a second. What's your bound testosterone? What's your free testosterone? What's something called your sex binding hormone globulin? Um, but when we check estrogen and all these hormones in your blood, it's simply what's available in your blood, right? Those can vary from day to day. It can vary from when you took your last dose of maybe certain medications. I want to know what your body's storing too. So you can look like you have non-existent estrogen in your blood, but your tissues are storing it. And we'll talk about what kind of test to offer um, when we want to look into that. One step further, we can look at saliva and urine testing, and that's what I was just talking about. Sometimes we want to look at cortisol values. What are your adrenal glands doing to support hormone function after your ovaries have shut down? It is now up to your adrenal glands to do that. Sometimes through life's paths and different journeys, the adrenals are too pooped out to do that. So at times we have to investigate that, see what's going on. We look at DHEA in the saliva and urine, and then progesterone, and then estrogen as well. We'll build upon that. Metabolic changes that you might be happening, and what we want to look at more from a blood value sense rather than blaming on hormones first is, for example, sleep, right? I'm looking for magnesium deficiency. If you need magnesium, often we need 300 milligrams before you go to bed to help sleep. Is cortisol spiking in the middle of the night? What about your progesterone? Progesterone helps sleep as well. So I'm evaluating that. What about hair loss? Well, rather than blaming it on, okay, well, you have no DHEA, I want to look at vitamin D. If your D's low, you will not be growing hair properly. You'll be losing it. Iron, ferritin, or your iron stores, those need to be proper. What about your testosterone? Do you have too much testosterone that's going what we call the 5 alpha formation? If you do, then you'll have male pattern hair loss. You'll have oily acne skin, maybe even some facial hair. So what's your testosterone doing? How's that full fat thyroid panel doing? You could have perfect TSH, perfect free T4, but you're not converting and using as active thyroid. That's why we check free T3. What's biotin doing? What's B12? Are you having heart palpitations? Welcome to the heart palpitation world. A lot of times, again, we do need to get checked out by cardiology, sure, but we're forgetting that just magnesium deficiency will throw you into heart palpitations. Low progesterone. I have so many people that go into getting heart different testing, and we just forget that, well, it's just low progesterone, or maybe it hurt helping, or it happens at a certain time of the month when progesterone's low, heart palpitations. Same with high estrogen. You can have heart palpitations then. Ferritin, the iron stores, if you have too low, heart palpitations. And then the $1 million question, weight. Got people coming in. Can you do anything about my weight? It's not that easy because I look at all these factors. I want to know how much inflammation you're holding according to your HSCRP, what's your B12 doing, thyroid, cortisol, your average sugar over 3 months, your hemoglobin A1C, what's your insulin doing, vitamin D3, hormone balance. If you have too much estrogen compared to progesterone and you're storing the estrogen, which leads to storing the weight. So we look at all these things. It isn't a simple fix. It's just let's throw hormones at it to do this and look at the step before the hormones, then we're ensured more of a longevity at me helping maintain that rather than riding this roller coaster. Stepping into nutrition, that is always important. Diet plays a huge role, but I do want to mention RDA's recommended daily allowances. Please remember that that's from the 1950s. So when we look at supplement labels on the backside, then they're outdated. It doesn't account for our foods nowadays. It doesn't account for our different disease states. So remember, RDA's probably not updated. So we need to consider different ones. Maybe we don't even need supplements. Maybe you can just get your nutrients from your food. Just depends on what we're working with, right? It's a personalized approach. We want to make sure that we're working with organic diet because these or these different toxins and chemicals coming off of inorganic food can mimic estrogen-like symptoms, and then they become what we call xenoestrogens. Our soil content is not as nutritious as it once was. They don't have as much vitamin content. We want to limit our alcohol. Limit will actually store estrogen and lead to a lot of weight gain if we're not careful, specifically the sugary wines. So we need to limit the alcohol. Allergens. We need to come into allergens come into play. What about the dairy? What about the gluten? That will lead to autoimmune possibilities or even just heightened cortisol. So we play a role in that. And then whole and processed food. We want to get as much fresh vegetables as we can, low sugar, natural sugars, no or little additives, preservatives, and food colorings. So we take diet into consideration. The best diet out there, I feel, that's got a lot of literature around more of a hormonal balance is probably the Mediterranean diet. Um, I'll leave that for, we'll come back to that. So assessing within the diet, looking at protein, most women aren't consuming enough protein. We need at least, I'd say 70 to 80 grams of protein at minimum. Looking at fiber to help bowel movements to push the estrogen. We'll talk about that. What kind of oils are you using? What's your gut status? Do you have a good microbiome? Are you eating too much soy? Now, soy is good. Soy does provide the phytoestrogens, but a lot of the soys are dirty soys, so that plays a role. I mean, we find that soys that are in in China, right, or even Japan, they are a cleaner soy, so we aren't seeing much cancers with that. But if you look at soy and how we eat that in the United States, it's due to the where soy is coming from. And then again, hydration. A lot of people are saying, I drink water, I'm getting the water that I need. But if you are adrenally taxed and you're very stressed and you don't drink enough electrolytes or have enough salt to go with that water, it will not get into the tissue. So you feel like you're drinking all this water and it's not doing anything. So hydration is very important. They do recommend half your body weight in ounces. When we look at foods that decrease estrogen, and again, if you're in menopause, you're probably thinking, well, I don't want to decrease my estrogen. Well, you do. We want to use it and lose it. We do not want to store it. So we should be eating at least some sort of cruciferous vegetables in our diet at least 3 times a week, if not more. Broccoli, cauliflower, cabbage sprouts, bok choy, Brussels sprouts, kale. Mushrooms have some good estrogen detoxification components. Red grapes, seeds like chia, flax, and sesame. Green tea is good, and then same with pomegranates. Foods that will increase the estrogen, and if you're estrogen dominant, that's something that you want to you want to eat these foods, but only in moderation. It's not something that we want to really rely on. But apples, apricots, bananas, cherries, dates, grapes, grapefruit, legumes, oils, and grains. When we look at hormones, and I've alluded to this before, we need to have a functional, we need to have a personalized perspective. We need to ultimately balance our estrogen and progesterone. So through that, sometimes we can guess and get a person's story and kind of figure out where they are, but sometimes we can't. Sometimes we just have to um, test for it. So once the ovaries stop producing hormones, the best defense to any sort of hormone production are the adrenals. So looking at that whole correlation, the adrenals are sitting on top of the kidneys. And when we have some sort of stressor, any stressor, could be a physical stressor, emotional stressor, it will signal the hypothalamus in the brain to signal the pituitary to signal the adrenal glands. We're going to produce two or three things. Number one, we are going to produce cortisol, depending on where you are with your adrenal resiliency. From that cortisol, we're going to produce epinephrine and norepinephrine, but we're also going to talk about a hormone called DHEA. That DHEA is going to contribute to any sort of hormone production thereafter. So adrenals are very, very important. And a lot of times as a compounding pharmacist, when hormone prescriptions are changed in if they're changing constantly, it's a clear sign that we don't have enough adrenal protection or adrenal support on hand to help maintain current hormone levels. Hans Sale in the 1930s came up with this adaptation syndrome. Um, and it's based off of stress. So in phase one, this alarm reaction, what happens is like if a tiger's coming out of the woods, our goal our body's job is to produce cortisol to stimulate epinephrine, norepinephrine to flee the scene, fight or flight, right? Sometimes people's fight or flight, or they live with a tiger every day. They've had traumatic events, moves, deaths, divorces, physical, emotional abuse. And at a certain time, their adrenals can no longer withstand that. So then they fall into this phase two stage of resistance. Eventually, if they don't do anything about that, we fall into a stage of an exhaustion. That's pretty rare, but it does happen. A lot of antidepressant resistance occurs in this, and no matter what you do, it's very hard to gain traction. So we don't want phase three. Most people are in this phase two resistance. Hormone pathway. So the adrenals in response to stress will make this hormone called pregnenolone. My personal opinion is a lot of people are offered pregnenolone as a supplement. It's very easy to get over the counter. I stay away from it. My job is to get your adrenals to do it. I don't want to supplement with it because once you supplement with it, you have no control of where it goes. So you can see up here with this pregnenolone, he has the opportunity to turn into DHEA, has the opportunity to turn to estrone, testosterone, progesterone, even cortisol. We cannot control it. So if pregnenolone gets too high, then we're dealing with maybe blood sugar problems, blood pressure problems. So we get a notation of what the level is in the blood, and if we're doing our job correctly, that should go up by itself. And then DHEA, which is also produced by the adrenal glands, will turn into three types of estrogen: estrone, estradiol, estriol. It will turn to testosterone, and then we also have the opportunity to make progesterone and then cortisol. I did have a note up here though, cholesterol and LDLs. Please, please, please pay attention to your LDLs. Typically, we want them to be under 100, but some doctors are getting so um, they want these LDL values to be very low. They want them in the 60s, they want them in the 50s if you have a high risk for cardiovascular disease. But we have to understand that low LDLs, you will not make your own sex hormones if that's the case, because that's the backbone to all that. We need the cholesterol to make to support our brain, number one, but also these hormones. And if we have low LDL, we will not be able to do so. So it's important. Here, this is a opportunity to show how influential the adrenal glands are responsible for numerous number of symptoms, right? So if we have too much cortisol and too much DHEA, or too much cortisol and not enough DHEA, all this can go wrong. So when people have adrenal problems, it will affect inflammation. We'll be in a pro-inflammatory state. We can't be in an anti-inflammatory, well, we will be in an anti-inflammatory state. We'll start having immune system problems. Our liver will start getting fatty. Will be more apt to have chemical sensitivity. So you're reacting to certain things. Gallbladder may be acting up. We can see that we have fat and protein metabolism. So digestion is going to be wonky. Protein absorption is going to be altered. So you think you're getting enough protein, but your body's not maybe breaking down and absorbing it. Thyroid's going to get wonky. Sex hormones are going to get wonky. We won't be able to regulate blood pressure. Here we might have some numbness, tingling, can't sleep, we're more anxious, we're more depressed, we're more having some brain fog issues. A bone, we're having hair loss, fibromyalgia-like symptoms, nail growth changes. All this can be part of the adrenal. So no wonder why it is so hard to track down. And we in the conventional space are going off into these different things, right? So if you look at these different types of circles, you can associate some medication with it, right? So here you're having adrenal problems, and if we're having glucose cravings and our insulin resistance, we might be on metformin. Oh, well, you're more inflamed. Okay, let's put you on some ibuprofen to counteract that. Oh, liver problems. You can't detoxify, so we're going to give you maybe a statin because your cholesterol is changing. Okay, well, with that statin, maybe we can't absorb protein and we're just, gaining some, um, gut mucosa breakdown leading to more leaky gut, and maybe we're going to be diagnosed with IBS diarrhea, IBS C constipation. So we'll see that. Oh, now your thyroid's going off, and we need some levothyroxine or Synthroid, and maybe we need something for sleep and anxiety, and then maybe an antidepressant. So we can see where we get to the point where it's going to become a polypharmacy situation. And then polypharmacy, and then I'll get off my soapbox. Polypharmacy is going to lead to more nutritional deficiencies, right? So it's a whole cascade. So again, if we're going to go to this root cause, we go to the adrenal glands and help adapt stress, whether it be emotional stress or physical stress. HPA imbalance spectrum, we talked about, we just need to, nip it as soon as we could. In the teens, we might see the stress response in the way of weight changes, anxiety, maybe we can't sleep, we're having painful periods, we're having more acne problems. If that progresses in our 20s and 30s, and we're still going to have those symptoms, but maybe we're going to have polycystic ovarian syndrome, have a tad of endometriosis, ovarian cyst, we won't be able to get pregnant, adult acne, thyroid starting to show, insulin resistance. And then when we get to the 40, 50s, same thing. Everything becomes more clinically worse. And we have more different body systems affected. Estrogen dominance, we talked about that. That could be just simple high estrogen. It could just be that you don't have enough progesterone to balance that estrogen. That can be in the course of premenopause where you don't have any progesterone, perimenopause where our cycles are becoming crazy, postmenopause is when you just don't have enough estrogen production at all. We can create an estrogen dominant situation when we have an overdose on bioidentical hormones. Sometimes we see that. Sometimes we're on synthetic hormones such as Premarin. That will create an estrogen dominant situation. Or maybe you're just not metabolizing your estrogen and getting rid of it because you don't have enough magnesium, because you don't have enough greens, because you don't have enough B vitamins. So when we assess the situation of estrogen dominance, we got to figure out why, right? And these are the different causes. These are all symptoms. Again, we kind of talked about this. There's a host of symptoms, right? And we can just do all this blame game, but ultimately, we need to think about estrogen. Estrogen linked to ovarian, breast, and thyroid cysts. Estrogen depresses thyroid output and increases TSH. So sometimes when we have too much estrogen by whatever means, we will have a higher TSH for thyroid. So we got to think about that. Is your thyroid acting up because your TSH is going up? Or is it because you have become estrogen dominant and it's mimicked off of that? So we got to do some thinking behind the scenes. Why do you have this estrogen imbalance, right? Is it an incoming estrogen problem? So if you're stressed and you have high cortisol, you will have high DHEA, like we mentioned. High DHEA will turn into high estrogen. So is stress driving this estrogen problem? Is it that you have a lot of synthetic estrogens, xenoestrogens? BPA could cause that. Untreated or milk treated with hormones could cause that. Are you over medicated? Are you consuming too much alcohol, which is promoting estrogen storage? Do you have your own source of fibroids and tumors, which are estrogen producing cells to begin with? Do we have estrogen outgoing problems? Are you not consuming enough of those cruciferous foods like I was talking about? Are you overweight, storing estrogen? Are you not having daily bowel movements, leading to estrogen's redistribution into the fat again? So if you don't have daily bowel movements, your estrogen is going to get restored. Gut health plays a role. Vitamin deficiency, specifically B vitamins and magnesium. Heck, genetics, that's a whole new thing too, looking at different genetic testing. What about drug interactions? That could be a part of that as well. I will mention endocrine disruptors. Endocrine disruptors are the hormones that mimic the actions of our own hormones and how they disrupt how they communicate. So example of estrogen are endocrine disruptors that could mimic our estrogen, our BPA, plastics, pesticides, heavy metals, cosmetic products, cleaning products. So we have to have a talk about endocrine disruptors when we talk about just overall hormone health. The prescription for hot flashes. What do we do for the hot flashes? Well, lifestyle. We want to reduce those hot flashes. Well, we could lose weight. That might be doing it. Smoking will promote hot flashes. Help identify and minimize personal triggers. Maybe just by drinking coffee, it throws you into hot flashes, right? So you're going to have to decide if you want that coffee or do you want the hot flash. What about cooling techniques, right? Wear loose clothing, dress in layers, fans, and then do we want to use prescriptions? So first lifestyle and then prescriptions next if needed. This is a lot here, and I'm not going to go through each one of them, but know that there are different types of prescriptions per se. There's vaginal moisturizers for vaginal dryness. We can use vaginal lubricants. And that's more for symptomatic measures. That's more localized, mild symptoms. If we get into moderate symptoms, then maybe we can go into topical vaginal estrogens. Remember topical vaginal estrogens? A lot of practitioners will not rely on them to get systemic relief. It's going to be more localized relief. So more or less, we see it a lot for just vaginal tone, people who have recurrent UTIs, things of that nature, vaginal dryness. And then if that goes beyond that and we need help with just more topical estrogens and even oral estrogens, then there's a lot of different there's a lot of different options for that. This is a Dutch case study. So Dutch is a dried urine test, and we'll use that as a measurement of what is going on in the tissues, right? So this is an example of I believe she was 68 at this time. We know she was in menopause. If we were to check her blood work, we know she would be of so low on the estrogen and very low on the progesterone. And it wouldn't give us an idea. You can't get down to that small of amount. Here we're looking at what's in the tissues and at specific small amounts because it's based off of how we're using our estrogens. So here I would expect this person to be in the purple box. That's exactly where a postmenopausal female should be. And we see that. That's progesterone. This person was on estrogen patch because she felt better on that. But with her estrogen patch, her hot flashes went away and her night sweats went away. But now she has fibrocystic breast. She has problems falling asleep. She has mood swings. She's having evening energy dip, bloating, dizziness. The problem being is that this practitioner did not give her enough or any progesterone to support that estrogen. So the practitioner now has given her an estrogen dominant state, cut off the hot flashes, but caused other problems down the road. So we know that she should be taking progesterone to help balance that, and then we would have that balance. So it gives us an idea about that. It will also pinpoint, well, why is she waking up in the middle of the night? So here we can see that on this waking curve right here, she is waking up with high cortisol. Her cortisol is peaking long before it should, and it's waking her up around 3, 4 a.m. So it kind of gives us a pinpoint there of what your body's using with cortisol. It will also tell us how you're utilizing your hormones. So here again, this E2 is higher because she is on a estradiol patch, but I want to make sure that she's not storing that patch because if she's storing that patch and the estrogen in it in her fat, she could gain weight and become more of an estrogen dominant state. So here it will show us how she's detoxifying. This first part is how she's eating greens or cruciferous vegetables and getting that estrogen out of the fat. Here we can see that this is dependent on B vitamin status, magnesium. She's a little bit lower on here, so I did recommend to up her magnesium a little bit more. So that's how you're detoxifying. And then this was giving us an idea of her overall cortisol. I talked about two markers, right? DHEA of the adrenal gland, long-term indicator of stress. What has your adrenal glands been doing? And that number will go down with age. So based on for her age, she should be between 500 to 1200, and she is. So that's appropriate. If she's had long-term, if she's had stress in the past, she recovered. And then this is day-to-day stress. How much cortisol are you producing over 24 hours? And it's pretty decent here. But she's not using her cortisol appropriately throughout the day. So it pinpoints of when she could be getting anxiety, getting those energy dips in the day, or unable to sleep. Bioidentical hormones. To maximize the benefits of bioidentical hormones, you need to make the brain healthy changes in your life. So it isn't about just an easy fix, band-aid approach of bioidentical hormones. You need to eat healthy, you need to take supplements when needed, you need to get more sleep, and exercising will have a synergistic effect. So we need to do all the things. And sometimes that's a bit hard, but to be successful in this, that is what we need to be doing. I do want to mention that estrogen transdermal versus oral. Estrogen transdermally, so this is estrogen applied on the skin or estrogen patches, have been linked to a lower risk of stroke, osteoporosis, um, gallbladder issues, and deep vein, so more clots than oral. So transdermal estrogen has been shown a little bit more protective than oral. That's just estrogen. We haven't talked about progesterone in this equation. We also need to talk about synthetic versus natural estrogen. Um, the conjugated estrogen is a synthetic estrogen. That's the Premarin. That is going to have completely different risk factors and side effects than the natural bioidentical estrogen. Same with the progesterone. It's commercially available called Prometrium. There's also synthetic progesterones called progestins. That's agestin, that's norethindrone, it's medroxyprogesterone. It does not reproduce the same actions of natural progesterone. So when you look at these terms and look at these medications, we need to distinguish if it's synthetic or natural. Conjugated estrogen, real quick, that is Premarin that comes from the pregnant mare's horse's urine. It's all synthetic. All this stuff that's in that Premarin is foreign to our body. We do not produce any of that. So we do produce estrone, that's about it, but all the other components we do not. Therefore, I'm a big proponent, more research on bioidentical hormones called estradiol or estriol. Progestins, here we see a study, effects of estradiol with microdose progesterone or medroxyprogesterone. Here's our clinical difference. We need to assess if it's progesterone that we're using or the synthetic medroxyprogesterone. Those different studies out there are going to produce completely different results. And because of that, that is why the FDA just removed the black box warning, and this is fall of 2025, for these sorts of hormones, because we have found that and they have recognized that we're talking about two distinct different drugs, synthetic drugs and bioidentical drugs. So all these scary things that you see on these different studies, you really have to pay attention to what they're using. Progestin side effects, that's the fake progesterone, is going to be increased appetite, weight gain, fluid retention, irritability, depression, headache, decreased energy. So that is the synthetic progestins. If we look at the estrogen plus progestin studies, it's going to show that estrogen does have scary effects. But again, it's because the progestin was not protective because it was not the progesterone. Same thing here. Same thing here. So the general guidelines and considerations that we have to think about this, and it isn't about this up, up and away. We have to be very mindful when we deal with hormones. Less is more. Efficacy is dependent on the route, duration, time of the month and the day and the base that we compound these or even commercial products use in their hormones. So it's again personalized. We want to go start low and go slow. We want to monitor levels in 90 days when initiating and then changing therapy. And then if you stay with the same dose, then we want to monitor every 6 months. We just had someone in here that's been on an estrogen patch for the last 3 months or 3 years, not a change. So we don't want to do that. We want to monitor it. You must combine diet and lifestyle changes. We want to notate that excess hormones mimic deficiency symptoms. So at a certain point, when you have too much estrogen floating around, it's going to shut down all your receptors. Your body's not going to know that it's going to think it's in a deficient state, and it's not. So really be careful. And with this being said, you've got to find a good practitioner that understands that. It isn't about just throwing darts at the wall. And prescribing is based on symptoms. We always want to test. We want to look at cortisol. We want to look at thyroids. We want to look at sex hormones. So, an example of this, vaginal dryness. Well, it could be caused by you not having enough testosterone. It could be caused because your thyroid levels are wonky. It's not always just the estrogen, right? Same thing, weight gain, sleep issues, irritability, cycle irregularity. Maybe it's not about the hormones. Maybe it's about having high cortisol and not a progesterone deficiency. So always test. Why compound? We are a compounding pharmacy. The dose is individualized. Commercial availability, there's usually 2 or 3 set dosings. A lot of times people don't need that much. We can use it in different percentages. We can tailor what you need according to different types of estrogen, estradiol and estriol. Individualized therapy. Do you want the cream? Do you want a troche to put on in a little lozenge to absorb it through the mouth? Or do we want to use the capsule? So again, it takes a certain practitioner and you have a conversation of what works well in your life. So what is next? Diet. Looking at your diet, we want to look at your blood work. We want to address the stress. Make sure you're exercising. Make sure you're sleeping. We want to find your community, right? So if you have a group of friends that are spreading the myths, like we talked about at the beginning of this, go to a practitioner that is trusted. And again, supplementation, you've got to build that foundation when I was talking about magnesium, B vitamins, vitamin D. And then David Bowie, aging is an extraordinary process where you become the person you always should have been. So aging is not always a bad thing. It's just there are tools in their tool chest to kind of help us with this aging and support our hormones and stress from here on out. Thank you.